Medicos. Good day to all of you. This is Dr. BK for you, and today I am going to discuss about the rectum and the anal canal. So, both the rectum and anal canal is the lower part of the digestive tube, and it is very important with respect to the clinical and surgical point of view. So our learning objectives for today, first I will be discussing about the rectum. So a short introduction about the rectum, followed by the situation and extent of the rectum, then curvatures of the rectum, then the interior of the rectum and relations, peritoneal and visceral relations, then the blood supply, supports and the clinical aspects. Now, we all know the large intestine starts with the cecum, and we call it as the colon, ascending colon, transverse colon, descending colon, and then the sigmoid colon. So beyond the sigmoid colon, the rectum starts at the rectosigmoid junction, and it is the dilated part of the digestive tube, the lower dilated part. So the cardinal features like your saculations and hostrations, appendices epiploicae, and then the tinea. So the tinea coli, tinea libera, tinea momentalis, tinea mesopolica, all these are absent in the rectum. Absence of tinea, you don't have appendices epiploicae, but rudimentary saculations are present, which I will be talking after a couple of slides. Okay, now the term rectum in Latin means straight. So rectus abdominis, muscle rectus sheath, all these. Anything rectum means it is actually straight, but this is true, or this term holds true only for the quadrupeds who walk on four legs. Only for them the rectum is straight tube. Whereas in case of humans, the rectum is not straight and it is bent forward. You have a flexure of the rectum which is maintained by the puborectal sling of the levator ani muscle. Because if at all the rectum is straight in humans, where we are bipedal and we actually maintain an erect posture, then what happens is we will not be able to hold the feces. There might be incontinence of feces. So fecal incontinence or rectal incontinence might take place if the rectum is a straight tube as it is found in the quadrupeds. So it is actually situated in the lesser pelvis. So within the pelvic cavity and behind the bladder, in case of males, behind the urinary bladder and also the prostate. Whereas in case of females, it is situated behind the uterus and the posterior wall, behind the posterior wall of the upper part of the vaginal canal. Okay, upper part of the vaginal canal and the posterior part of the body of the uterus. So this, the anterior relations for the rectum in case of the females. So the rectum is actually a muscular tube which you are able to see here, 12 centimeters in length, starts from the rectosigmoid junction. Okay, so here it is the rectosigmoid junction at the level of third sacral vertebra. At the level of third sacral vertebra, And then what happens? It ends at the anorectal junction, where the commencement of the anus, which is slightly below and anterior to the tip of the coccyx. So slightly below and in front of the tip of the coccyx, the anorectal junction is present, where the rectum suddenly narrows down, because immediately just above it the rectum is very much dilated, and it is called as the rectal ampulla. Okay, so any dilated part is ampulla, which I already told in my last class also with respect to the prostate. Okay, so the rectal ampulla suddenly narrows down at the anorectal junction, which is lying slightly below the tip and to the front of the coccyx. Now, the anterior and the posterior walls of the rectum, they approximate, usually only when the fecal matter passes. Then what happens, due to the peristalsis, it transmits. Otherwise, the anterior and the posterior walls are approximated. So, if you take a section of the cross section of the rectum, it appears as an antero-posterior, it appears as a transverse slit. When these two walls are approximated, and when you cut it, it appears as a transverse slit. Now, curvatures of the rectum. So mainly you have curvatures antero-posteriorly. So they are actually vertically disposed. You have antero-posterior curvatures. Before that, if you look at the pores, the upper part runs downwards and backwards, middle part vertically downwards, and then the lower part downwards and forwards. And abruptly what happens? It turns downwards and backwards to continue as the anal canal. Okay, so that is the course of the rectum. Okay, downwards and backwards, where it follows the shape of the sacrum, then vertically downwards, and then downwards and forwards, and abruptly it turns downwards and backwards to continue as the anal canal. So antero-posterior curves, you see one curve, the upper curve and then the lower curve. The upper curve is actually called as the sacral curve, follows the concavity of the sacrum, S3, S4 and S5, the last three sacral vertebra, follows the sacral curve or the sacral concavity, the first upper antero-posterior curve. The lower curve, antero-posterior curve, is actually called as the perineal curve, and this forward bending, this is actually convex to backwards. The perineal curve is convex forwards. This is mainly maintained by the puborectal sling of the puborectalis muscle. Okay, so now you know the rectum is not a straight tube in the humans, because there is a flexure or antero-posterior curve. Lower curve is actually called as the perineal curve, and this is actually pulled forward by the puborectal sling. Okay, so the importance of the puborectal sling, all those things I have discussed in my pelvic diaphragm class, so you can just watch in the pelvic diaphragm. In detail I have spoken about the importance of the puborectal sling. It helps to mainly again hold the weight of the feces, one of the factors which is responsible for maintaining the hold of the feces. Otherwise again rectal incontinence will occur. So like you have curvatures or bends antero-posteriorly, rectum also has lateral curvatures. They are actually three in number: upper, middle and lower. The first curvature is actually convex to the right, and it is present at the level of third and fourth sacral vertebra. The middle curvature is actually convex to the left, and it's present at the sacrococcygeal junction. This is the most prominent lateral curvature of the rectum, the middle curvature. And then you have the lower curvature, which is again convex towards the right side, and it is present at the level of tip of coccyx. Okay, so that is the lower curvature. So first one to the right, second one or the middle one to the left, and third one to the right. So totally 3 curvatures, 2 towards the right side and 1 towards the left side. Now, what are the significance of the lateral curvatures? So more than the anterior-posterior curvatures, the lateral curvatures are important, because from the hollow or concavity of the lateral curvatures, you can see folds arising like this. They are actually mucus folds and also called as Houston valves. Okay, they are actually called as the Houston valves. Now these curvatures, they represent the primitive or rudimentary circulations, which is the cardinal feature of the rest of the large intestine. So from the hollow of these curvatures, you can see the folds of mucous membrane called as Houston valves or rectal valves. They are horizontal in direction and semilunar in shape. Okay, so they are horizontal in direction and they are semilunar in shape. So each valve is a reduplication of the mucous membrane, and deep to the mucous membrane we have the submucosa and also the circular smooth muscle layer. Okay, so it's a reduplication of mucosa, submucosa and the smooth muscle of the muscularis externa. Okay, the 4 layers of the GIT you should always remember. Okay, so lateral curves gives rise to the rectal valves. Now I'll come back to the rectal valves again after some time. Now with respect to the relations, peritoneal relations, the upper 1/3 of the rectum is covered by the peritoneum in the front and the sides, and this part is related to coils of intestine and the sigmoid colon. Upper part, upper 1/3, which is covered by peritoneum to the front and also to the sides. From the sides, it actually reflects to the lateral pelvic wall. Okay, and forms the pararectal fossa. Middle 1/3, this part is only covered by the peritoneum anteriorly, and then it reflects onto the bladder as the rectovesicular pouch. Okay, it reflects as the rectovesicular pouch. So the lower end of the rectovesicular pouch is actually 7.5 centimeters from the anal opening. Okay, so forming the rectovesicular pouch. Lower third of the rectum, the dilated part, rectal ampulla, is devoid of peritoneum. No peritoneum in the front or on the sides, and it is related to the base of the urinary bladder and the ampulla of vas deferens, seminal vesicle, and also to the posterior surface of the prostate gland in case of the males. Okay. So this part actually lies below the rectovesicular pouch in the males, and in females the rectouterine pouch. So here you are able to see the rectum with the peritoneum upper 1/3, front and the sides. So it forms the pararectal fossa on either side. You are able to see the pararectal fossa filled with fat, loose packing material. Then this part, middle third, also you have a space which is called as the pelvirectal space. So pelvirectal space mainly contains your levator ani muscles and condensation of the pelvic fascia. So the pelvic fascia from the lateral wall of the pelvis as the parietal layer, endopelvic fascia, then reflects on to the viscera as the visceral layer of pelvic fascia. So that thickening of the fascia might forms the lateral ligaments of the rectum. Middle rectal vessels actually pass through the lateral ligaments of the rectum. So pelvirectal space, lower part of the rectum and the anal canal, on either side you have again a fat filled space which is called as the ischiorectal fossa or ischioanal fossa, which is below the pelvic diaphragm. Okay, so these are all spaces which is necessary for the distension of the rectum. So when the fecal matter passes, so these spaces are mainly for the free distension of the rectum. At the same time, it is filled with the fat, because fat acts as a loose packing material. Otherwise, if the fat is not there, then the rectum might move this way and that way, and it might get impacted or injured, or sometimes it might also collapse. So they all acts as a support for the rectum. Visceral relations in front, in males, it is related, as I told you, to the base of the urinary bladder, seminal vesicle, and then the ampulla of the vas deferens and lower part of the prostate. All this is separated from the rectum by a fascia, which is the rectovesicular fascia of Denon-Villiers, which is the fusion of a primitive rectovesicular septum. Okay, so this fusion, primitive pouch, actually what happens is forms the rectovesicular septum. Okay, so this is the lower end of the rectovesicular pouch, which is 7.5 centimeters from the anal opening. Okay, so it is related to the base of urinary bladder and terminal part of ureter, seminal vesicles, ampulla of vas deferens and prostate. In case of females, it is related to the posterior surface of the body of the uterus and posterior wall of the upper part of the vagina. So it is separated from the uterus by the rectouterine pouch. This rectouterine pouch lies 5.5 centimeters from the anal opening. So rectouterine pouch is at a lower level as compared to rectovesicular pouch in case of the males. Okay, so that is the anterior relations of the rectum in case of the females. And again, this is actually separated by the fascia, rectovaginal fascia. In between the posterior wall of the vagina and the anterior wall of the rectum, we have the rectovaginal fascia. Now, posterior relations. So we have removed the rectum behind. The relations, we have it in the midline and also posterior in the midline and also posterolateral. In the midline, you come across ganglion impar. So fusion of the last sympathetic chain, ganglion on the either side. The last ganglion is called as ganglion impar. Three pieces of sacrum and coccyx, S3, S4, S5, and then coccyx, ganglion impar, and you come across median sacral vessels. Okay, in the midline you will see median sacral vessels. They are the direct branch of abdominal aorta, and then superior rectal artery also passes behind the rectum and then pierces the wall of the rectum. Laterally, you see the origin of piriformis, coccygeus muscle and levator ani, and then you come across the sympathetic chain, which we have already seen here. On either side you have the sympathetic chain, pelvis splanchnic nerves, and then the pelvic spinal nerves. Okay, so these are the pelvis splanchnic nerves, and then the sympathetic chain, piriformis muscle, coccygeus muscle. All these forms the posterolateral relations, and then here in the midline median sacral artery you are able to see, and laterally you have the lateral sacral vessels. That is the lateral sacral vessels, and in the midline median sacral artery, which is the direct continuation of the abdominal aorta, last branch of the abdominal aorta before it actually divides into the common iliac arteries. Okay, so that is about the visceral relations. Anterior relations differ in males and females, whereas the posterior and posterolateral relations is the same, and lateral relations, upper part it is related to the pararectal fossa, middle part pelvirectal space, and lower part ischioanal or ischiorectal fossa. So now coming to the interior of the rectum, mainly we come across two types of folds. You see longitudinal folds. They are actually temporary folds. The longitudinal folds are temporary folds. They are seen only when the rectum is empty. When it is distended, these folds disappear. So when the rectum actually expands during the passage of feces, what happens is these folds, they smooth out or disappear. The next type of folds which we see here are the permanent folds, and they are called as Houston valves. So this is what we have discussed in the lateral curvatures of the rectum. From the hollow of the lateral curvature or concavity of the lateral curvature, we can see these folds projecting into the lumen of the rectum. They are reduplication of the mucous membrane, as I told you, then submucosa and the circular smooth muscles. They are mainly responsible for holding the weight of the feces. Okay, so one of the things which I have shown in arrow, so like this, all these are considered as Houston valves. They are actually horizontal in direction and semilunar or crescent shaped folds. There are 4 total in number, the Houston valves, of which the first and the third is the constant one. The second and fourth are inconstant, they might be absent. Okay. The first valve is seen at the rectosigmoid junction at the level of S3 vertebra, 12 to 13 centimeters above the anal orifice. The external orifice or the anal orifice. So 12 centimeters above, so usually projects from the right wall, right lateral wall of the rectum. The second valve is again inconsistent valve, not always constantly present, 2 to 3 centimeters above the third valve. Okay, so 2 to 3 centimeters above the third valve it is present. Third valve is very important. It is constant and it is 5 centimeters from the anal orifice. So at the level of rectal ampulla, you can see this third valve, which is constant valve, always present, and from the right anterior wall it projects into the interior of the rectum. So it is situated at the upper end of rectal ampulla. As I told you, the level of fifth sacral vertebra. Okay, so superior valve, middle valve, and the inferior valve, of which the third valve is which we have seen now at the upper part of the rectal ampulla is the most constant. Now this valve sometimes, instead of being semilunar, it may form a complete circular fold interior, like a sphincter, and it is called as the Nielanton's sphincter. Okay, so that is actually called as the Nielanton's sphincter. So part above this are different in development. This develops from the pre-allantoic part of the hindgut. Pre-allantoic part of the hindgut. Below the third valve, it develops from the post-allantoic part of the cloaca. Okay, post-allantoic part of the cloaca. So above it is pre-allantoic part of the hindgut derivative, post-allantoic, because cloaca is that part of the hindgut which is below the opening of the allantois. So allantois is a primitive excretory organ which becomes urachus, attached to the apex of the urinary bladder, and then finally in adult it is represented as the median umbilical ligament. Okay, so all that we have already seen well and enough in the urinary bladder and also in the peritoneal folds. So you can refer to those classes, urinary bladder class and also to the peritoneum class, where we have seen about the ligaments of the peritoneal ligaments. So above it is pre-allantoic part of the hindgut, post-allantoic part of the cloaca. So mainly responsible for holding the weight of the feces. So very constant valve. So its function is indispensable. So while introducing especially a sigmoidoscope or a colonoscope, the surgeon has to negotiate this valve. So passage of instrument is the surgeon has to be very careful so that he does not damage this valve. So if forcefully the instrument is passed, then it might tear the valve and it might lead to rectal incontinence. Okay, so that is about the Houston valves, which is very important. Totally 4 valves, of which first and third are constant. Third one is very important and it is responsible for holding the weight of the feces. So coming to the supports of the rectum, we have already discussed about one support, tuborectal sling, which maintains the forward perineal curve or the forward bend of the rectum. Then the levator ani muscle, you are able to see here, pelvic diaphragm, which forms the pelvic diaphragm. Again, what happens? Helps to hold the weight of the pelvic viscera. Okay, tuborectal sling maintains the anorectal fissure. Then endopelvic fascia, then perineal body. So where the levator ani and all the muscles of the perineum, a fibromuscular node which gives attachment to almost 10 muscles. So again, if this perineal body is damaged, then any of the pelvic viscera, whether the bladder or the uterus in case of females or the rectum, might prolapse. So chance of prolapse are there. So perineal body is again support. Fascia of Waldeyer. So from the posterior wall, it is a condensation of the pelvic fascia extending from the posterior wall of the rectum to the coccyx. Fascia of Waldeyer. Lateral ligaments is the condensation of the pelvic fascia which transmits the middle rectal vessel. So this I have already told you in the pelvirectal space. Okay. So condensation of the pelvic fascia, reflection of the pelvic fascia from the parietal layer to the visceral layer, there it forms a thickening as the lateral ligaments of the rectum. Okay. So that is the reflection of peritoneum, and this is the levator ani muscle. Then of course, as I told you, loose packing material, your ischorectal fat and fat on the pararectal fossa. Okay, so this does not allow the rectum, only allows for distension, but prevents the rectum from going and impacting onto either the lateral wall of the pelvis. So coming to the arterial supply of the rectum, it is mainly supplied by 5 arteries, of which the superior rectal artery is unpaired, middle and inferior rectal arteries are paired. Superior rectal artery is a branch of inferior mesenteric artery. So enters from the posterior wall of the rectum, then divides into right and left branches, and then it forms plexus. Okay, so 2 sets of plexus it forms, and then it anastomoses with the inferior and middle rectal arteries. Middle rectal artery is a branch of internal iliac artery, and inferior rectal artery is a branch of internal pudendal artery. Okay, so inferior rectal artery branch from actually internal pudendal. There is a mistake, typographical error. It is internal pudendal artery. Then it is also supplemented by median sacral artery, also gives some branches to the rectum. So the venous drainage of rectum is very important and significant with the clinical point of view. Mainly corresponding veins, arteries, so superior rectal, middle rectal and inferior rectal veins. But the mode of formation is very important. 2 sets of plexus you see here. One is the internal venous plexus and other one is the external venous plexus. So the internal venous plexus is actually situated deep to the mucous membrane, in the submucosal layer, deep to the mucous membrane. You are able to see the internal venous plexus, rectal plexus, and it is above the Hilton's line. So I will come to what is Hilton's line in the anal canal. External plexus is actually subcutaneous, which is present between the skin and the external anal sphincter. So this is the external anal sphincter. Between the external anal sphincter and the skin, here you see the external rectal venous plexus. Both these plexus, they communicate with each other. Okay, and from there what happens? From the internal venous plexus, they drain into the superior rectal vein. So this internal rectal venous plexus is also called as annulus hemorrhoidalis, which is actually situated at the junction of the rectum and anal canal, anorectal junction. Okay, so internal rectal venous plexus, also called as annulus hemorrhoidalis. Now, from this internal rectal venous plexus, what happens is long veins, 6 long veins, they pass along the anal columns and submucosal coat of the rectum. So ultimately they will form 2 veins, and ultimately single superior rectal vein, which will continue as inferior rectal vein to join the splenic vein. Okay. From the middle of the plexus, middle rectal vein, they arises from the sides of the rectum, and they might go and they will drain into the internal iliac veins, middle rectal veins. Okay, from the middle of these plexus. Then, from the lower part, inferior rectal vein arises and they drain into the internal pudendal vein. Okay, so inferior rectal vein drains into internal pudendal vein, middle rectal vein into the internal iliac vein. Superior rectal vein continues as inferior mesenteric vein. So this internal rectal venous plexus, which is present in the lower part of the rectum, is a site of portosystemic anastomosis or portocaval anastomosis, because superior rectal vein drains into splenic vein, which is again draining into portal vein, portal system of veins. Middle and inferior rectal veins, which is draining into internal iliac and internal pudendal vein, they are actually part of the systemic veins. Now, of these 6 veins, the radicals, the venous radicals of the 11 o'clock, 3 o'clock and 7 o'clock position, okay, 11 o'clock, 3 o'clock and 7 o'clock position are distended primarily in any varicose veins. They become first varicosed in any pathological conditions, that is, if there is a portal hypertension or portal obstruction. So these veins are the first to get dilated, and they are called as internal piles or primary piles. Okay, mainly the veins of the 6, you are able to see these 3 are actually enlarged, whereas these remaining 3 in between are not enlarged. The first to enlarge is the 11 o'clock, 7 o'clock and the 3 o'clock position veins. So distended varicose veins above the pectinate lines are called as internal hemorrhoids or internal piles. Okay, so radicals of superior rectal vein, they get distended, and sometimes they might also prolapse through the rectum and also get strangulated. Below the line, actually below the Hilton's line, these veins are actually external hemorrhoids. They are because rupture of subcutaneous veins. Okay. So internal piles is mainly characterized by passage of blood red stools. Along with the stools, you get bright red bleeding color, bleeding will be bright red color, and it is painless. It is actually painless, and as I told you, sometimes in chronic patients it might get prolapsed and it might get strangulated, so which requires surgical intervention. Whereas with respect to the external piles, it is not that much serious, but it is very painful because of the perianal veins, but it does not require any surgical intervention. But it is very painful because of the presence of the fibroelastic septa which is present. Lymphatics, upper part of the rectum mainly drains into the common iliac nodes. They actually starts as the plexus, periglandular plexus, and then submucosa and intramuscular plexus. So from there, the lymphatics arise from these plexus and they go to the upper part, they go to the left common iliac nodes. Middle part of the rectum, they go to the internal iliac nodes. And lower part, some of them passes below the levator artery, some above the levator artery, and finally they might drain into the internal iliac nodes. Whereas lowermost part, that is below the anal valves, they go to the horizontal part of the superficial inguinal nodes, horizontal set. Superficial inguinal nodes has a horizontal and a vertical set. Horizontal set mainly drains the lower part of anal canal, vaginal canal, glands, penis, and all those structures. Okay. Now, the lymphatics actually they pass as longitudinal channels. They don't pass as a transverse vessels. They pass longitudinal channels. So they don't get obstructed in case of the rectal carcinoma. Okay. So in case of the rectal carcinoma, what happens is only at the final stages obstruction takes place, but initially it causes no obstruction. Unlike the other parts of the gut, especially in your coils of small intestine or large intestine, usually in the early stages they don't cause any obstruction because the channels are passing longitudinally. Nerve supply. So preganglionic fibers are sympathetic from L1 and L2. Okay. They are actually stimulates the sphincters and vasomotor. Parasympathetic is secretomotor S2, S3, S4. So relaxes the sphincters and stimulates peristalsis. So prolapse of the rectum, it might be due to the defective pelvic diaphragm or the perineal body in case of females. If it is damaged, mainly during a process called as episiotomy, if it is not sutured properly after labor or parturition, it might lead to not only the uterine prolapse but also rectal prolapse. So weakening of the muscles or supports of the rectum might lead to rectal prolapse, increased intra-abdominal pressure, chronic cough or chronic constipation, all those things. It might be partial or complete. Partial is the mucous membrane alone actually prolapses. Complete is with the submucosa and the muscle layer also prolapses. So that is the complete rectal prolapse. Rectal incontinence is again the tuborectal sling is actually damaged, or the one of the Houston valves is actually torn or damaged, might lead to rectal incontinence. The patient might not be able to hold the feces. Okay, and the distension of the rectum mainly is sensitized by the pressure. That is how the rectum is able to demarcate between whether it is what is passing through the rectum is fecal matter or a flatus. The flatus is what the gas we pass. It is based on the pressure on the rectal walls. Then rectal examination, digital examination per rectum. So in case of males, prostate gland, the median lobe of the prostate, terminal part of ureters, base of the urinary bladder, seminal vesicle, vas difference, all those things can be palpated, and your bulb of the penis, perineal body, anteriorly. Posteriorly, we can palpate for any enlargement of the sacral lymph nodes, and lateral walls, again lateral lymph nodes, and the distension of the right wall of the rectum might also indicate appendicitis in some cases. Okay. So in females, for rectal examination, again mainly Douglas pouch, rectouterine pouch can be actually assessed, and uterus, posterior wall of the vagina, all those things can be assessed in case of the females. Posterior and lateral, it is the same whether it is males or females. Only the anterior part, the structures differ. Polyps. So growth, rectal polyps, actually growth from the lining of the wall of the rectum creates polyp. It might be a single polyp or sometimes multiple polyps. So polyps, rectal polyps, what happens is it might be harmless, but sometimes as days advances, after a couple of or 3 to 4 years, it might turn into rectal carcinoma. Okay, so rectal cancers are neoplasms. Most of the polyps actually turn into neoplasms, but they are not dangerous. Not all of the polyps has to turn, but if at all rectal carcinoma occurs, in 85% it is only rectal polyps. Now coming to the anal canal, our learning objectives for anal canal will be a short introduction of the anal canal, then followed by the situation, course and extent of the anal canal. Then interior of the anal canal is very, very important, features of the interior of the anal canal. Then anal sphincters, and followed by that your blood supply, lymphatics, venous drainage and clinical aspects. So last terminal end of your digestive tube is the anal canal, 4 centimeters in length and situated in the perineum. So below the pelvic diaphragm, not in the pelvis, but below the pelvic diaphragm in the perineum it is situated, and it is surrounded by the internal and external sphincters, and the lateral walls are actually approximated. So it is exactly perpendicular to the rectum. The rectum, the anterior and posterior walls are actually close together, approximated, but whereas in this case the lateral walls are actually approximated. So in a cross section it appears as an antero-posterior slit. Okay. So the sphincters helps to keep the lateral walls approximated in a closed position, and only it relaxes during the defecation. So approximately 4 centimeters the length of the anal canal, or to be precise 3.8 centimeters from anorectal junction, slightly in front of the tip of the coccyx. Okay. So where the rectal ampulla narrows down, and from there to the external anal orifice. So an opening which is situated 3.8 centimeters below to the tip of the coccyx is actually the anal orifice. So this is your anal canal, antero-posterior slit. It appears because the lateral walls are actually kept closed by the sphincters, which you are able to see here. Now you are able to see the external anal sphincter. Deep to it you see the internal sphincter. In males, anteriorly it is related to perineal body and also to the bulb of the penis and the spongy urethra. Okay, bulb of penis and spongy urethra, which is seen in the corpus spongiosum. In females, it is related to the lower part of the posterior wall of the vaginal canal. Okay, and also the perineal body, lower part of the posterior wall of the vaginal canal and also the perineal body. Behind it is related to anococcygeal raphe. Okay, and on either side we have a space, again ischiorectal space or ischiorectal fossa or ischioanal fossa filled with fat. So the major content of it is fat, and of course on the lateral wall of the fossa you have the pudendal canal where it transmits certain structures. So now coming to the interior of the anal canal. The interior of the anal canal can be divided into three parts: upper part or area, then intermediate or middle part, and then the lower part. Upper part is 15 mm or 1.5 centimeters long. It is limited below by the pectinate line. So this wavy line is actually called as the pectinate line. So from anorectal junction to the pectinate line, this part is actually called as the upper part, which is 15 millimeter in length. So as any part of the gut, it is lined by simple columnar epithelium. So it is the lining of your small intestine, large intestine, colon, rectum, all those things. Not the okay. So lined by the simple columnar epithelium, you are able to see permanent mucus folds. Permanent mucus folds. They are actually called as the anal columns of Morgagni. Anal columns of Morgagni are permanent mucus folds. They appear bright red in color because of the radicals of the superior rectal artery. You can see that, and very prominent in children. Okay, so contains the radicals of superior rectal vein. Sorry, I told this as artery. So immediately deep to the mucus. These are actually called as anal columns of Morgagni, and they are not temporary, they are permanent folds. So they don't get disappeared. And above the pectinate line. So the lower limit of the upper part is the pectinate line. So above the pectinate line. So one of these, as I told you, 6 to 10 of this, what happens is when they get dilated, especially the 3 o'clock, 7 o'clock and the 11 o'clock position, they actually form the primary internal pipes. Okay. So what happens is these anal columns below are connected by the anal valves. Okay. So semilunar mucus folds, these folds are actually called as the anal valves. The upper surface of the valves are lined by stratified squamous, simple columnar epithelium. The lower part is actually lined by the stratified squamous epithelium. Okay, so anal valves. So semilunar mucus folds which connects the lower end of the anal columns. So the position of the valves only is represented by the wavy pectinate line, or also called as the dentate line. It's also called as the dentate line. If this one of these valves is torn due to the passage of hard feces, then it is actually called as the fissure in ano. So or anal fissure. So anal fissure, again, it's a very painful burning sensation while passage of stools. Usually you feel the burning sensation after the passage, and it might last to several hours. Most common cause is passage of hard stools, that is constipation. Okay, so anal fissure. Now, what happens is a ruptured valve. Sometimes, if it is forming like a tag of mucus membrane, then that is called as the sentinel pipe. Deep to these anal valves, you see anal sinuses. They are small spaces where the ducts of the anal glands open. Okay. So mainly what happens, they keep the area moist and lubricate for the passage of the fecal matter. Okay. So that is the anal sinuses. the depth of these valves, you can see spaces which receives the opening of the anal glands, ducts of the anal glands. So sometimes any foreign body might get impacted and it might lead to infection. Anal papillae are epithelial, projecting from the free margin. Not always present. Sometimes if they present, they are called as anal papillae. The epithelium projecting from the free margin, and they represent the primitive anal membrane. So the remnants of anal membrane, or they represent the primitive anal membrane. They are actually called as the anal papillae. So these are anal glands. So the ducts open into the floor of the anal sinuses. Intermediate part, which is situated below the pectinate line or dentate line, and the lower limit is actually marked by the Hilton's line or white line of Hilton, 15 millimeter in length, and it is also called as pecten zone or pecten area, also called as pecten zone or pecten area. So the Hilton's line represents the lower border of internal anal sphincter. So this is your internal anal sphincter. These three parts, 1, 2 and 3, are the external anal sphincter. So lower border of internal anal sphincter corresponds to the internal anal sphincter and lined by stratified squamous epithelium. So here itself we have seen anal columns above, simple columnar, but below, lower surface. From here the stratified squamous epithelium, but absence of sebaceous glands and sweat glands. It is developed from endodermal cloaca, this part. Now in living persons it is bluish pink due to the presence of internal rectal venous plexus. Okay. So the internal rectal venous plexus is actually present deep to this pecten zone. Now, lower part 8 mm is darkly pigmented and actually is developed from the protodium, ectodermal derivative. So it has got all modalities of the skin with the sebaceous glands, sweat glands, and in males you also see coarse hairs. As I told you, it is deeply or darkly pigmented, and skin folds radiate on all directions. Because of the fibroelastic septa, they form a corrugated appearance, and it is called as corrugator cutis ani. Okay, last 8 mm or 0.1 centimeter, lowermost part of the anal canal. Okay, so is actually developed from the proctodium. So the pectinate line, or this line which demarcates the upper 1/3 from the middle 1/3, the importance of the pectinate line is the buccal-cutaneous junction above, which is lined by stratified squamous simple columnar epithelium, below by the stratified squamous epithelium. Superior rectal artery below, which is supplied by inferior rectal artery. Then of course drainage, superior rectal vein, below middle and inferior rectal vein. So superior rectal vein to portal system, middle rectal vein into, or inferior rectal vein into the cable system, vena cable system. Upper part actually drains into internal iliac nodes, so lower part drains into superficial inguinal nodes, horizontal set. So lymphatics don't crisscross. There is no crossing over of lymphatics at the pectinate line, and it is called as the watershed line. Okay, that is called as the watershed line. You see watershed line in case of umbilicus. Again, above actually they drain into again axillary nodes, below they drain into the inguinal nodes. So upper part developmentally from the endodermal cloaca, Lower part develops from the proctodium. So below the pectin zone, it develops from the proctodium. Autonomic nerves above, so insensitive to modalities of the skin. Lower part actually is somatic spinal nerves, pudendal nerve mainly supplies, and anorectal disease actually comes from this zone. So if a surgeon wants to inject into the piles, internal piles, it is given above this pectinate line, otherwise the patient would refuse treatment if it is not anesthetized because it is extremely painful. So above the pectinate line only the injection for the internal piles is given. So the white line of Hilton, which marks the lower limit of the middle 15 mm of the rectal canal, as I told you, anal canal, is bluish pink above and black skin below. So this is more behaves like a skin, our skin of the body, with sebaceous sweat glands, and it marks the lower end of the internal anal sphincter, lower end of internal anal sphincter, and ischiorectal abscess may communicate at this level of the Hilton's line or below this. So coming to the anal sphincters, two sphincters we have. One is the internal sphincter and other one is the external sphincter. Two sets of sphincters are present. Internal is involuntary. It is nothing but a thickening of the circular muscle of the anal canal. It is not under our willful control. It is present deep to the external anal sphincter and surrounds the upper part of the anal canal. And its lower margin is corresponds to the white line of Hilton. External sphincter you see as three sets. You have superficial, subcutaneous, and the deep. Subcutaneous, superficial, and the deep part. Okay, so three parts, they are actually voluntary and extends along the whole length, whereas internal sphincter seen only the upper part, extends only up to the upper part of the anal canal. So here you are able to see the subcutaneous part, then you see the superficial part, and then the deep. Three parts of the external anal sphincter. So immediately deep to skin, you see the subcutaneous part. So it is surrounds the anus and separated from the perianal skin by external venous plexus and fibroelastic septa. Fibroelastic septa and external venous plexus separates the sphincters from the skin. Superficial part is actually elliptical and surrounds the lower part of the internal sphincter. Lower part of the internal sphincter. So it arises from the coccyx anococcygeal raphe and getting inserted into the perineal body. The next is the deep, surrounds the upper part of the internal sphincter. No bony attachment from the anococcygeal raphe and the perineal body, where the superficial transverse perineum is continuous with each other. Okay. So here you are able to see the sphincters, especially the external anal sphincter, the deep part of the external anal sphincter attached to the perineal body behind to the anococcygeal raphe, no direct body attachment, and where the superficial transverse perineum is continuous with each other. So blends with the puborectalis muscle, and as I told you, it forms an anorectal ring, or muscular ring at the anorectal junction, which is mainly formed by this deep part of external anal sphincter, puborectalis muscle, and internal sphincter. All these forms the anorectal ring or intersphincteric groove, which can be palpated in a rectal examination. Again, it is responsible for maintaining the fecal continence. So blood supply we have already discussed in the rectum. So upper part drains into superior rectal artery, lower part into inferior rectal artery, veins through two plexus. So lower part external venous plexus to inferior rectal vein, upper part goes to superior, lower part into inferior and middle rectal veins. So perianal veins here, lower part communicates with the annulus hemorrhoidalis and inferior rectal veins. So damage or rupture of the perianal veins only creates external piles. So upper part lymphatics into interiliac nodes, lower part into superficial inguinal nodes below the pectinate line. We have seen all this in the pectinate line. The same features only it is repeating as blood supply and lymphatic drainage. So again, I have discussed about what is internal piles above the pectinate line. It is painless and distension at 3 o'clock, 7 o'clock and 11 o'clock position of the radicals of superior rectal vein. External veins is actually perianal rectal veins from the external venous plexus. Fistula, anal fistula. So mainly it starts from the infected tubular anal glands. From there it might form a ischiorectal abscess and it might open into the anal canal. So when this abscess makes a communication with the anal canal, it might spread as a pentadactyl. So anteriorly, posteriorly, above, below or behind the anal canal and communicate with the other side as a horseshoe shape. And this abscess, sometimes this fistula, from here it might communicate below the levator ani or it might go above the levator ani pelvic diaphragm and also to the upper part of the anal canal. Proctoscopy is an instrument which is used. Anoscopy or proctoscopy is just used to view the anal canal alone, 4 centimeters. Whereas sigmoidoscopy is used to view the sigmoid colon. Okay. So for this, the surgeon has to negotiate the Houston valves. He has to clear the Houston valves and only then he will be able to view the sigmoid colon. Colonoscopy, the whole colon to view, actually it is called as colonoscope. And malignancies are also common in anal canal, not only in rectum, even in anal canal. Other congenital anomalies include imperforate anus. So due to persistent anal membrane, failure of development of proctodium or persistent anal membrane. If the anal membrane has to rupture, only then the proctodium will communicate with this. Otherwise, the imperforate. There is no opening in the anal canal. Rectovesical or rectourethral fistula. So this is normal, but you will see a communication between the rectum and the bladder. Rectovesicular fistula or rectourethral. Sometimes it might open into the urethra. So that is called as rectourethral fistula. So most commonly urorectal septum, when it divides, sometimes it might, instead of coming down and dividing completely, it might bend forwards. So then what happens? A communication is established between the anal canal and the urinary bladder. Same in case of females, rectovaginal fistula. So you can see a communication between the anus and the vagina. Sometimes what happens, both all the anal opening, urethra and the vaginal canal all might have also a common opening. Stenosis and anal atresia. So stenosis is narrowing of the lumen of the anal canal. Anal atresia is again, it might end as a blind tube or it might fail to develop, atretic. Okay. So that is all about the rectum and anal canal. Thank you very much for your patient listening.